again, huh? There we go. So in our digital imaging systems, we have indirect capture and direct capture. So as far as resolution goes, CR and DR and is still subpar in relationship to screens and films. So the question then becomes, why is it that that we still use? Why is it we don't still use screens and films whenever the spatial resolution is better than film? That is basically because contrast resolution, and what they refer to that in digital world is dynamic range. Dynamic range in CR and DR is much better. So, and that's what I'm about to say is more obvious whenever we get into things where screens and films and fog, especially, creates such an issue with the image, that the benefit of CR and DR and that computer algorithm bringing out that contrast really shines. So in things like feet, where we used to have to shoot 2 images for each foot, or maybe set a technique for what portion of the foot actually hurts. You can actually get from toes to the proximal portion of the foot and be able to visualize all the way across, from distal foot to proximal foot. Also, the T-spine, we used to have to shoot 2 views of the AP of the T-spine, because the upper portion of the T-spine, if we shot for the lower portion of the T-spine, the upper portion would be completely burned out. You just couldn't see it. Or if we shot for the upper portion of the T-spine, the lower portion will be so light you couldn't see it. With a DR image, you can see both ends very well. So the dynamic range is so much better that we can visualize the detail that is there, and what little amount of detail that we lose is, I won't say it's irrelevant, but it is less. If you don't have the contrast, you can't see the detail anyway. Right, so in an absence of contrast, then spatial resolution is less important. So the dynamic range is what it's all about. That's your contrast resolution in CR and DR. So CR and especially DR has superior dynamic range. So speed we talked about just a little while ago. So speed is the relative efficiency of an image receptor system. So screens and films were 400 speed, CR was 200 speed, meaning that you need twice as much exposure for something that's 200 speed as what you would with 400 speed. Okay, so when we went from screens and films to CR, then we had to double our exposure in some capacity. So we increased our KVP by 15% to do that. And then when we went from CR to DR, then we went back to a 400 speed system, and instead of reducing the KVP back down to where we had it with screens and film, we decreased our mass, cut our mass in half. So with CR, what we saw was an increase in dose, even though the selling point for CR was we have the potential to reduce dose. In reality, dose really went up. There's just no 2 ways about it. You can do the math all day long, and I think it would bear out that when we made that switch to CR, dose went up, especially for each exposure. For certain people, reducing the repeat rate, it probably went down. But I think for the overall population, I think it probably went up. But when we went to DR, it certainly went down. Certainly over CR and a little bit over screens and films as well. So speed, when you see speed, that's the relative speed of the image receptor system. You can juice the speed just a little bit. If you get your super user could get in and increase the relative speed in your imaging system so that you could further reduce that exposure back a little bit. So I don't know how high you can go with the speed, but I've heard anecdotal evidence that you could increase your DR systems up to 800 speed. I don't know that to be true. So speed just means greater efficiency, and it is a 1-for-1 thing. 200 screen, a 200 speed system is twice as fast as a 100 speed system, meaning that a 100 speed system would need twice as much exposure as a 200 speed system, right? And the same thing happens with 200 to 400. With a 200 speed system, you would need twice as much as a 400 speed system. So going from a 100, or let's say a 400 speed system to a 100 speed system, what would you need? 4 times, right? 4 times the exposure. All right, so we're just going to go through all that because we talked about all that. Quantum model is still theoretical, still testable, but you're probably not going to see it because, again, of the sensitivity of your image receptors now. But if you run into a question, your questions that you might be asked about quantum model is all about mass. What causes your mass to get too low? Thin anatomy, potential for quantum model. Yeah, because your mass is low. High KVP to maintain the same exposure. If you increase your KVP, what happens with your mass?
Drops.
You decrease your mass. So the potential for quantum model exists. Faster image receptor speeds. All right, and this is where there's really a disconnect between reality and theory. Faster image receptor speeds. So you've got a 400 speed system you're using a high KVP on, right? Where you might not have the problem on CR with quantum model, you might have it on DR, theoretically. In practice, probably not. Probably not. But again, still registry testable. So file all that stuff away. Anything that reduces your mass, anything that causes your mass to be low, be it high KVP, you phototime it. You increase your KVP. What happens with your mass? Goes down, right? Potential for introducing quantum model, theoretically anyway. So that's just a speckly appearance. Happens when mass is too low, and it's the analogy there is as if you listen to radio, you're driving out of range of the broadcast system or the station that you're listening to. You're driving from here to Dallas, let's say. What happens to your signal?
Breaks up.
It starts to break up. So it's kind of the same thing. It's a digital in the sound, that sound fuzziness sound that you might get. It fades in and out. That's basically what it is. It's weak signal. You don't have enough of something is mass. Contrast density really is controlled in your computer algorithm. Theoretically, you could control both contrast and density in your beam by not having enough or having way too much exposure. But really, in a digital world, what that looks like is, again, you really messed something up. You're only going to see quantum model if you really mess something up. You're really going to see only the fluctuations in contrast and density if you really mess something up. Where that might play in, though, in a practical sense, is that your computer algorithm is trying to set your overall contrast density and your exposure number by everything within the collimated field, right? So if you over-collimate, your exposure field is too small, it might have some effect. If you under-collimate and your exposure field is too large, likewise, you may have some issues there, especially in your index number. All right, so let's say we shoot a hand on an image receptor size that's the full size of your image receptor. The collimated field is the full size of your image receptor. What your computer is going to try to do is it's going to try to pick out, well, it's not really going to try to pick out, it's going to take measurements all the way across that image receptor. So what it's getting is a lot of direct exposure to the image receptor. So it reads that direct exposure as overexposure. So even if you use a perfect technique, since you got all that area that's so dark, it's going to read that as overexposure, and your index number is going to be off the charts, overexposed, right? So that then, applying the computer algorithm to that might have some effect on your overall contrast. Certainly the overall density, but the contrast in the hand itself may have some issues there as well. So really, contrast and density is controlled by the computer algorithm. The computer algorithm Bouchon's has a diagram, a couple of diagrams of computer algorithm. And what it is just kind of a line chart with all these little spikes and valleys in it that visually you have a hard time making sense of it. If you could get into the system and view those computer algorithms individually, what you might find before you get to the actual representation of the computer algorithm is what we refer to as the H&D curve. I think we touched on this in our first imaging class in your freshman year, but H&D curve is just an S-shaped curve that describes relative speed of the image receptor system and what your contrast looks like. So the portions of the H&D curve, we have shoulder up at the top, and that's the top of the S. And then we have the toe portion at the bottom. And those are kind of high exposure, out of the range, low exposure, out of the range. Straight line portion is what we're most interested in. And what you see on the straight line portion is how vertical it is, right? If you remember from the first semester, if we have a image that goes from very light exposure to very dark exposure with very few differences between those exposures, then we have high contrast, right? It goes from clear to completely opaque with very little difference in between them. It goes from white to black so quickly that you can't really tell any difference between them. You have high contrast, okay? So very vertical H&D curve would be representative of things like rib x-rays, let's say, because you want to see the bones, right? You want to see the bones in the rib x-rays. You're not interested in the lung markings. But same anatomy, thoracic viscera, thoracic cage anyway, the chest, I say, because I just went from soft tissue to bone, the chest, right? Chest computer algorithm for the thoracic viscera, though, is not going to be very vertical. It's going to be more horizontal because what are we looking for? Are we looking for the bones where we want the bones to stand out? Answer is no. We don't. We want the bones to kind of dissolve a little bit so that we can see that soft tissue, right? So where your computer algorithm needs to be high contrast, the one for your chest x-ray needs to be lower contrast. So the H&D curve, even though we don't use it all that much, we used to use it more for processing than anything else. Our chemicals that we had to run our films through would get exhausted after a while, and it really you shoot a perfect image and you'd run it through the processor and it'd come out just this milky looking mess. So the processing chemistry got exhausted after a while, so we'd have to do, quality control on the processor like every day just to test the chemistry out. And then we'd have to plot it on the H&D curve. So we don't really have to do that anymore, right? But the H&D curve still is representative of your computer algorithm. You have 300 little spikes and valleys on this bar graph. What does it tell you? Well, it depends. Where are the spikes? Are they at one end? Or are they at the other? Are they in the middle? Are there valleys in between them? As opposed to vertical means high contrast. Horizontal means low contrast, right? So in a lot of cases, they'll still use the H&D curve as a visual representation of what that computer algorithm is supposed to give us, high contrast versus low contrast. Does that make sense? Nice and straight line portion. We're not going to run through the numbers. Okay, so some of these issues we talked about before. Dropout artifact was specific to CR systems. If we have those needle phosphors, and one of those phosphors, I need more phosphors than this. So one of those phosphors burns out, which is prone to happen. And you got all these, and all of a sudden that one right there stops working. You just don't get a density on that area. And what that gives you is just, it's almost like you've got a star in the middle of an image, and it's on every single image. And the only thing that's going to cause that is either dirt on the imaging plate, or you got a needle phosphor that just quit working, and that's what we refer to as a dropout artifact. Non-uniformity would be where you've, like we talked about the laser last week. You remember the laser? You had the fast scan, and you had the slow scan. The slow scan was the travel of the imaging plate, and then you had the fast scan going back and forth, right? Well, if you had non-uniformity, which might have is a non-consistent travel of the plate in your slow scan. Spatial accuracy, eraser, making sure that the eraser plate, the lights in the eraser plate, eraser bank were working well. So with geometric factors, we have same problems with geometric factors as CR and DR as what we had before. That is our SID and OID issues we're going to talk about later in the semester. And then we've got distortion, part beam alignment, focal spot. All of that still applies, anode gill effect. All of that's still going to apply, but we still have issues with sharpness or recorded detail specific to our CR and DR systems. We kind of talked about that as well last week, and that is that what we have, just like on your computer, your sharpness on your computer or your television is controlled by two things. They're interconnected, but it's two things. Be it the DR plate or the display, you got two things, right? You got a matrix. Right, so the matrix just describes the number of individual pieces that you have. Right, so matrix is the overall thing. That's that 1020 by whatever, 1020 by 1070 or whatever. That's your matrix size. But if you have, well, since that one over there doesn't work anyway, this. If you have an image receptor that's, say, that big, and you've got individual pixel, just refers to picture elements. So your image receptor is that big, so it'd be roughly 10 by 12, and you only have 4 pixels, then your matrix size is 2 by 2, right? You got these great big pixels. If I were to shoot somebody's hand and I only had 4 pixels, what would that image look like? Trash. It'd be trash. You couldn't even make out exactly what it was, right? So our overall image size is 10 by 12, but if I were to break these pixels up into little bitty individual pieces, now I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 by 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's 9 by 13. 9 by 13 instead of 4 by 4. Which one's going to give you a sharper image? 9 by 13. So now you can make out that it's a hand. It's an ugly hand, right? But you can make out it's a hand on that 4 by 4. You couldn't even tell it's a hand. Right, so two different things. One is the matrix size. The bigger the number, right? The bigger the number, 9 by 13 is bigger than 4 by 4, right? So the bigger the number, the more pixels you can fit, the smaller the pixels become, then you get a better resolution, right? Now, think about this. What if I were to draw this out on that entire board, right? Make all of this, scale it up. So it's the same, same number, same matrix size, 9 by 13 on something this large. What would I have? Okay, magnification, but let's say I'm not even taking an image. How big would these individual pixels be on this entire whiteboard. That'd be big, right? So now I'm back to the same problem I had before. I got big pixels, right? So what I need is small pixels in a large matrix, right? So I need that not just in my image receptor. I need small pixels, small individual picture elements, not just in my image receptor, but also in my image display. We talked about that a little bit last week too. What's your resolution on your monitors and light? Maybe. Yeah, they're basic computer, uh, computer monitor. What's the resolution in the doctor's office in the light or in the reading room? A lot more. Yeah, on a level of 50,000 by something, right? So spatial resolution in their office is much different than spatial resolution in the Lightroom. So the image naturally looks a whole lot different in their office than what it does, or even at their home, than what it does in the Lightroom. We still call it Lightroom in the reader room, whatever. It's a lot different. Everything about the image that they see is different than the image that you see. So it's not just the spatial resolution, it's contrast resolution as well. The dynamic range is totally different. So the bit depth is a whole lot deeper than what you're seeing on your computers. So, you see an image, the index number looks good, the collimation looks good, everything looks good, technically wise, but the image just isn't quite where you would like to see it. Do you adjust the image and then send that to the radiologist? No, you send the original because what doesn't necessarily always look good on your computer might look much better on the radiologist's computer. You can actually post-process some things off of the image that the radiologist would need to see. So if you really feel like something needs to be processed, if you feel like you need to do some tweaking on the image, what you need to do, and to send that image to the radiologist, what you really need to do is save the original, save a copy of the original, tweak it, and then send them both, right? Because your image is going to look totally different than the radiologist. So quality control that we can run, I think I talked about this last week, and most or all of your digital systems are going to come with some resolution test tools in the system. Have you ever been watching a TV show and it went off air, and for just a split second you see like a pattern come up that had different lines and different shapes and things, and it didn't really look like it was by accident? Maybe, yeah. Okay, so your TV stations are going to do some quality control on the signal that they send. So what they'll have are resolution patterns that they kind of test their signal against, so that they make sure that they don't send you a fuzzy image. And your DR systems and CR systems are going to have those built into them as well. So they're going to read how well the display system is going to be presented. But we also have some things that we have to test the X-ray tube as well. All right, so things that can affect spatial resolution X-ray tube, blooming, right? You remember what blooming was? You stand on the rotor too long, you build too large of a space charge grows, you get an increase in the focal spot size, you lose spatial resolution. Over time, your X-ray tube can lose spatial resolution as well. So not just your display, but your X-ray tube can lose some spatial resolution. So we have a line pair per millimeter test tool, and that's what this thing right here is. I'll pass that around and you can kind of take a look at it. And we looked at a representation of that the other day, and the smaller the lines, where you can still see the separation between the lines, the better the resolution. So that's what a line pair per millimeter test tool is. They have another one. It's called the STAR test pattern. It's a little more complicated to use. Accurate, but it's a little bit more complicated to use. But what we'll do with our test tools is to measure both the length and the width of the focal spot. So we'll have to shoot that with it parallel to both axes of the focal spot. So the focal spot's not just a round thing; it's actually a square on the focal spot, on the focal track. It's kind of square. So we have to measure in both dimensions to get an accurate representation, an idea of what our focal spot looks like. Okay. So, modulation transfer function, you can look up definitions for modulation transfer function. And really, what we have is that because sharpness of recorded detail is so dependent on contrast resolution, spatial resolution, contrast resolution, modulation transfer function for our purposes is basically going to be the marriage of the two. It's not just the contrast resolution. It's not just the spatial resolution, but it's good contrast, excellent contrast resolution with adequate spatial resolution. Okay. So any questions on all that? I know the DR system's going to get, DR videos will get deeper into all that and what I just did. The magnification, of course, is just size distortion. It changes, or it occurs by changing SID and OID. So our quality control for magnification is a number of different things. One is that we have to have a distance indicator present. That distance indicator can be almost anything. You probably worked on a system that had a digital display. As you increased your SID, it told you what the increase was. Especially on your portables, though, which may have, is just a tape measure. Right? It sticks off the bottom, and you pull the tape measure out, and you measure how far out you are. Those used to be standard on pretty much all X-ray tubes. Most of your X-ray tubes now, I think, are going with a digital display or marks on the ceiling or something that indicates exactly what your SID is. Just so you know, on your portables, you pull that thing out, and you measure. Don't just let it go. It's kind of like your tape measures at home. You'll break the end of it off, let it come back in. Your quality control on that is that if it's broken off, somebody's going to have to take that collimator housing off and replace the tape measure, right? So don't just let it go. You make it work for other people. So distance indication, the quality control for distance indicator is it has to be within 2 inches of the SID, or 2% of the SID rather. So at 40 inches, it'll be 0.8, right? At 72 inches, it'll be 1.4. So it's got to always be present, it's always got to be present, but magnification is always present, and it's most observable on spherical shaped objects. And that is because if you have something that's perfectly round, I know the skull is not, but it's the closest thing that we've got. Well, how can you get, let's say, the parietal bones closer to the image receptor? How can you do it? It's a trick question. You can't, right? Because, it's kind of round. So you've always got to increase in OID. So you always have some degree of magnification. You always have magnification present no matter what you're shooting. Even if you're shooting hands, you're going to have magnification because you can't put bones directly on the image receptor, right? So even if it's minuscule and almost imperceptible, you're still going to have some sort of physical magnification of the object. You can mitigate that, you can reduce it, but you can't completely get rid of it. And you can't really do anything about it if you've got a spherical shaped object. So with magnification, regardless of how we got to it, we've got a loss of sharpness recorded detail. So 3 different ways to calculate magnification factor. image size over object size, SID over SOD, image size over object size is equal to SID over OID. We went through that in the math portions. So 1 times anything is what? The number that you multiply it by, right? So 1 times 2 is always 2, 1 times 3 is always 3. So a magnification factor of 1 indicates that there is no magnification, but magnification is always present. So your magnification factor is always going to be 1 point something. So again, on hands and fingers and whatnot, it's going to be 1 point something very small, right? If we shoot an AP chest, then the magnification of the part is going to be a little bit more than that. If we use 40 inches instead of 72 inches, again, it's going to increase it even more. So image size is always greater than 100% of the object size. The display, though, in your digital imaging systems might not bear that out, might not look like it. You know, again, if you increase your collimation, it may make your object look larger, it may make your object look smaller. So the display and the actual magnification is not necessarily the same thing. So the way that you would determine your magnification on an imaging system, you know, on a digital imaging system would be to use those tools that you can get into to actually measure the size of the object. All right. So SID. Changes in SID without any other changes. You got a lot of stuff that happens. You have a change in exposure, not so much density, but exposure, according to the inverse square law. You have a change in sharpness that increases at greater SIDs. You have a change in magnification. It decreases, the amount of magnification decreases with increased SID. And it has no effect on contrast. Has a lot of effect on density, no effect on contrast. So changes in SID. We have 40 inches. We've got quite a bit of magnification to the point that we've missed the costophrenic angle here. We can still see it over here. Unfortunately, though, we've overexposed patient's neck on this one. In this position, almost clipped that lung, right? And what this is, I think, supposed to be is a comparison between AP versus a PA of the thumb, right? So the thumb, remember, is the only finger that we routinely shoot AP, right? Rotate the hand around, shoot AP instead of PA. So we get magnification on the PA as opposed to the AP, reduced magnification, because in that case it reduces OID, which is our next thing though. All right, so OID, changes in OID. We can potentially have a change in image receptor exposure. Remember, to density, image receptor exposure, we're going to use them interchangeably. Image receptor exposure is more specific. Density, I should go back in and edit that out. But image receptor exposure potentially can change with a change in OID. So why don't we necessarily have to have a grid for shooting portable chest X-ray?
That's penetrating much.
Test question. What's that?
You're not penetrating much.
Well, that's valid. You're not penetrating much. You got a lot of soft tissue. Well, you got some soft tissue and you got a lot of lung, right? But there's a test question that's going to come at you about chest X-rays specifically, and that is because it utilizes a natural air gap. So how's the air gap technique work? Most of the time we talk about air gap, we're talking about lateral C-spine, right? So with a lateral C-spine, we have natural increase in OID. So what are our interactions inside the patient? We get penetration without interaction. We get photoelectric absorption, and the third is scatter, right? So scatter. So with if my image receptor were to be right up against my neck, and I create scatter radiation, and the scatter is going this far. I mean, it's a steep angle scatter, right? So it hits inside my inside of my body, and from right here, it scatters at that angle. Is it still going to hit the image receptor? Yeah, it is. If I back the image receptor up over here, what's going to happen? It's going to miss it, right? So the air gap, in theory, anyway, is equivalent to a low ratio grid. And with the increased NOID, if the increased NOID is significant enough, then we may lose some image receptor exposure, which, would affect your, not really your density, but your index number. So if you have, OID changes, we hadn't done OID changes yet, have we? I mean, we have in context to some other stuff, but at any rate, you can test this. Take your image with no OID, increase no OID, increase your OID, take the image again, compare your index numbers, see what they look like. Y'all know I'm opinionated, right? My opinion is that it's not as significant as what Bouchon makes it out to be. But is there some scientific, foundation to it? And the answer is yeah, absolutely. You should be able to see a difference in that, but is it really as effective as a low ratio grid? Maybe a really low ratio grid. So if you do that, you test this hypothesis, then even if you've got grids, because it's supposed to take the place of low ratio grid, see what technique you have to have in order to reintroduce that bring your index number back up to where it should be. Does that kind of make sense? And see if that, if it bears out what Bouchon says that your technical factor changes should be. So we lose density or lose image receptor exposure because scatter misses the image receptor. The effects on contrast now just aren't going to be really any effects on contrast. You probably are not going to see all that much of a difference between the two. But you could certainly compare both of those, your image receptor exposure and possibly the contrast by using the air gap versus using the actual grid, seeing which one gives you a better image. So the effects on sharpness are reported detail. The more you increase your OID, the more sharpness you're going to lose. All right. So with OID change in sharpness for reported detail, how can you reintroduce the sharpness? SID. With an increase in SID, right? So you can see this in practice, really. On a sunny day, it seems like every time I talk about, the shadow of the sun, it's a cloudy day. But on a sunny day, what's your shadow look like?
Sharp.
It's sharp. Even your head is sharp, right? So if you're walking under a street light at night, what's your shadow look like? It's pretty sharp, right? Your head maybe a little bit less sharp. You're walking, in your house under incandescent light or LED light that's not, like fluorescent light. What does your shadow look like? It might be okay, but it's not as sharp, right? So what's the variable there?
Distances?
And did you grow whenever you walked into the house?
Yes.
You did.
Yes.
Your shadow did, right? Your shadow did, but you personally, you're the same size, right? But the SID, the OID didn't change. The SID changed dramatically between the house, the street light, and then certainly the sun, right? So your sharpness is, brought back even though your relative OID didn't change. Your sharpness increases with the increase in SID. So with the increase in OID, we get magnification and size distortion. So all of that. All right. So Some things, though, we talk about sharpness of recorded detail in certain projections, and we also talk about better visualization of the projections, like an L spine. Right? Recenter that a little bit better. L spine. Which projection of the L spine opens up the intervertebral joint spaces the best in a frontal top view? PA or AP?
AP.
Who says AP?
I think it would be PA.
Okay, I got two.
I think it would be PA.
Why?
Well, like when they do a lumbar puncture, we always have them. Well, I guess no, wouldn't that be AP because you're doing fluoro and it's opposite.
Good observation.
So it would be AP. I don't know.
Bingo, beam divergence. So this guy doesn't have much of a lumbar curve, but he does have some. All right. So your beam divergence is, center of the central ray should be hitting right about here, right? Right, well, right about there. And the disc spaces are at an angle like this. There's one that's pretty perpendicular. The disc space is pretty, perpendicular to the image receptor, which would be parallel to the central ray. But the rest of them are at an angulation. If you flip them around, like so, then they would be more consistent with the divergence of the central ray. Right? Can you kind of see that?
Yeah.
Okay. So this is registry testable. The disc spaces are more parallel to the divergent central ray with the patient, PA for a lumbar spine. So the question is, why don't we do our lumbar spines PA? What's that?
I said a lot of the patients handle that.
That's number one. Ever had a backache? And that's the other one. Yeah, you can't get the patient into the position, one, because their back hurts. And laying on their stomach isn't going to be an option. But the other one is your OID, giving us some magnification, is here for the, or here, the AP, as opposed to it would be this much for PA. Right? So we lose sharpness of recorded detail. Do we get some distortion of the anatomy? Yeah, probably. How can you mitigate the distortion of the anatomy? How can you reduce that lumbar curvature? What's that?
You increase your SI.
I kind of got to work that out.
Maybe.
Yeah, maybe, but you still got to
You're saying decrease the curvature of the spine.
Decrease
Just
the
put something
curvature
under
of the
their legs.
bingo.
Yeah.
Bend the legs. Bend the legs. How many of y'all bending your legs for your KUBs and your APL spines? I didn't think so. How many of y'all are shooting your APL spines? Probably not shooting a whole lot of APL spines, but your KUBs on expiration.
Oh yeah,
Are
for
you?
sure. Yeah.
No? Well, okay. So that's probably the last thing we're going to do today, but I don't necessarily disagree with that. Shooting them on inspiration. A lot of your doctors want you shooting them on inspiration. Why is that? As you inhale, it's going to push the diaphragm down. Pushes the diaphragm down, and you can include more anatomy, right? So a lot of your doctors, want you to shoot on inhalation to depress the diaphragm so that they can get the entire abdomen on the image. Okay, probably not a bad idea. But what do you increase? You increase the thickness, potentially increase, depending on what specific anatomy you're looking at, maybe increase OID, decrease sharpness of recorded detail of that object. Historically, with screens and films, if you increase that thickness on inhalation, what you're going to get is more scatter and you're going to reduce contrast. What's the main thing that controls your contrast now? Computer algorithm, right? So you're really seeing a loss of contrast if you shoot on inhalation, and the answer is no, not really. Really? Lose a little bit of sharpness? Well, if it's bad enough, you're probably going to see it anyway, whatever the pathology is. abdomen's got a horrible contrast anyway, you know? So, if shooting on AP, I wouldn't, shooting on inhalation rather. I wouldn't get into much of a twist about that. Any questions? All right, we'll pick up there on Tuesday. Yeah, we did actually.